Hi everybody, this is Dr. Ihab Abdurrahman Ihab Tarawa, consultant of acute care medicine at Soba University Hospital, professor of medicine, University of Khartoum. We are still doing our course, basic emergency care course. This session is about shock. Objectives of this session: recognize signs of shock and poor perfusion, perform critical action for patient with shock, assess fluid status, select appropriate fluid administration based on patient age, weight, and condition. Recognize some conditions like malnutrition, anemia, and burn, and adjust fluid resuscitation accordingly. To manage shock, you have to master certain skills. You need to start with how to manage airway, how to administer oxygen. You need to know how to place IV line, assess fluid status, and to do fluid resuscitation, to manage burn, how to do needle decompression, three-sided dressing for pneumothorax, open pneumothorax, how to do source control, bleeding source control, like compression, tourniquet, uterine massage, and to do trauma secondary survey. Remember, management of shock, which is C, circulation. You have to start with ABCDE approach. Start with airway, breathing, then circulation. And then you go through sample history, and then you do secondary survey. Shock is a serious condition. If not recognized and treated quickly, it can lead to death. Shock is tissue hypoperfusion. Body is not able to deliver oxygen to vital organs. Uncorrected poor perfusion, the organ will stop functioning due to lack of oxygen, and then there will be tissue death. Shock in infant, children, and elderly, it progresses quickly, so it has to be recognized promptly. Shock is recognized in three windows: brain, skin, and kidney. In the brain, tissue hypoperfusion will lead to irritability, altered mental status, confusion, and it can progress into coma in severe cases. In the kidney, it manifests as reduced urine output. Skin, because of the severe vasoconstriction, you get cold and mottled skin and delayed capillary refill. At the same time, you will recognize feature of sympathetic outflow in patient with shock, and that manifests as tachycardia, tachypnea, sweating, plus blood pressure could be maintained early, especially in young adult, because they have strong sympathetic outflow, and then the blood pressure will drop. When the blood pressure is maintained with feature of shock and sympathetic outflow, that is compensated shock. When the blood pressure starts to drop, this is uncompensated shock. The goal of initial assessment to identify shock and to try to find if there is any reversible cause. And the management of shock, it is mainly by maintaining fluid status with adequate resuscitation, by fluid, by blood product, or by inotrope, and at the same time you have to improve oxygen carrying capacity, and at the same time you need to do source control. Shock is classified into four types: hypovolemic, distributive, obstructive, and cardiogenic. In hypovolemic, there is fluid loss, could be vomiting, diarrhea, excessive burn, and excessive urination or poor oral intake. When there is loss of blood, then this is hypovolemic hypohemorrhagic shock, as in hematemesis, melena, postpartum bleeding, or trauma leading to bleeding in different areas like the lungs, the abdomen, the pelvis, or external bleeding. Distributive shock due to abnormal relaxation and enlargement of blood vessel, as in sepsis, spinal cord injury, and in allergic reaction. Obstructive shock due to poor filling of the heart, as in pulmonary embolism, tension pneumothorax, and cardiac tamponade. Cardiogenic shock when the heart failed to pump blood effectively, as in cardiomyopathy and in arrhythmias. As in any patient who is critically ill, patient with shock, we start with A, B, C, D, E. We do airway, breathing, circulation, disability, and exposure. And when we are doing the primary survey, if we find anything, we have to treat immediately, and then we start again from A, B, C, D, E. After we stabilize the patient, then we go through sample history, symptom and sign, presence of allergy, medication list, past medical history, last oral intake, and exposure. And after that, we go through the secondary survey. During this process, whenever there is acute issues, we have to stop and start from A, B, C, D, E. We have to ask if there are any vomiting or diarrhea and for how long. As we know, fluid loss from vomiting and diarrhea can lead to severe dehydration and shock. Estimation of the fluid loss can help us to predict the resuscitation. We need to ask about hematemesis and melena, that is blood in the vomitus or in the stool. Stomach and intestine can accommodate large amount of blood before it is revealed outside. Patient can present with shock before you can see the blood. When the blood is digested, it appears as black blood as with coffee ground or melena. If there has been any vaginal bleeding, is the lady pregnant or recently pregnant? When was the last menstrual period and any missed period? Vaginal bleeding can be related to pregnancy. A woman may not know she is pregnant in early pregnancy. Also, some ladies might have ectopic that rupture and lead to significant bleeding. In addition, some ladies can bleed from uterine or cervical mass. Ask if the person has or had chest pain. Chest pain might suggest heart attack, and heart attack can lead to muscle damage, ischemic cardiomyopathy, and this will reduce the pumping ability, which can lead to shock. Presence of fever can suggest infection and sepsis. In sepsis, there is what we call distributive shock, relaxation of the blood vessels, and lead to leak of fluid inside the tissues, and this can lead to lowering of the blood pressure and shock. Ask, was there any exposure to toxin, medications, insect sting, or other substance? This can signify severe allergic reaction, which can lead to anaphylaxis and distributive shock. Overdose of many medication, including blood pressure and seizure medication, can cause shock. Tissue hypoperfusion is seen in the skin, in the kidney, in the brain. The brain is one of the last organs to be affected by poor perfusion. If the brain does not have enough blood flow and oxygen to function, this is a sign of severe shock. So you need to ask if there are any altered mental status, irritability, confusion, and coma. Is there any usual sleepiness? As we mentioned, you do the primary survey, then after you stabilize the patient, you go through sample history. We discuss symptom and sign, and then after S, you go to the A, allergies. You need to ask if there is any allergy to certain medication or any substance, or exposure to any sting or so. Severe allergic reaction can lead to shock, and because of distributive shock and relaxation of the blood vessel. Then we ask about medication, if there is any new medication or change in medication dose. New medication or change in medications can cause allergic reaction or unexpected side effect. Overdose of some blood pressure and seizure medication can lead to hypotension and shock. Some medication like blood thinner, anticoagulant can lead to bleeding. Past medical history can help us to identify causes of shock. Pregnant lady or recent delivery can be associated with postpartum hemorrhage or rupture ectopic. A patient with recent surgery can have postoperative bleeding or infection leading to sepsis and septic shock. History of heart attack, patient with heart disease are at risk of worsening heart function. And presence of HIV increase the risk of infection and sepsis. Last oral intake, ask when did the patient last eat or drink. Person who is not eating or drinking can have dehydration. In addition, presence of fluid of stomach can affect our intervention if we are going to intubate or going to the operative room. Events surrounding current illness. Was there any trauma? Trauma can lead to obvious external bleeding. In addition, it can lead to hidden bleeding in the chest, abdomen, pelvis, and the thigh. These areas can accommodate large amount of blood and lead to shock. Also, patients with trauma can have tension pneumothorax or pericardial tamponade. Trauma to the neck can compromise the airway, and it can lead to cervical spine injury, which can lead also to shock. Events surrounding the illness, presence of recent infection, it can progress into severe infection and sepsis and lead to septic shock. Take home, in patient with shock or suspected shock, start with primary survey A, B, C, D, E. Management of shock, start with management of airway, breathing, then circulation. After you stabilize, then you go through sample history. Sample history can help us to recognize the probable cause of shock and also to identify risky conditions that can affect our management, and also it implicates the way we're going to manage certain conditions. So go through symptom and sign, allergy, medication, past medical history, last oral intake, and events surrounding the current illness. Thank you, and we'll see you in the next session.